Hi, I'm Debbie Cassada. I'm the site coordinator with the Amarillo campus. We are at the Sim Central and we're going to go over a few things with you today. This is Janie Hester. She's a respiratory therapist and one of my many children. So she's going to educate you. Take it away, Janie.
Hi everyone, I'm just going to pretend like this is my patient and I'm going to go through a few of the oxygen modalities and how we start to work with that stuff and what all you need to do. So I'm going to pretend like I'm going into the room. Good morning, sir. My name's Jamie. I'm a respiratory therapist. I'm the breathing lady today. I see your oxygen isn't so great. I'm going to check your wristband here. Can you tell me your date of birth? Perfect. Okay, sir. Your oxygen's sitting at 88, so I'm going to put you on a nasal cannula with a little bit of oxygen here. The doctor did put in an order since that is a medication. So we always have to have an order for oxygen. So, this is our nasal cannula. And your nares inside go down. So we're going to make sure this cannula points down in your nose like that. And we're going to wrap it around your ears. And then we'll tighten it. We never do it behind the head because your patient can choke them if it is that way. Okay. Let's try a couple liters. I'm going to start at 2 liters and see if that helps us. Okay. Your SAT is 93 right now. We like it about 94 and above in the ER. So I'm going to go up a little bit more. We'll try 4 liters. Since I went above 3, we'll definitely put some water on that oxygen just to keep you from drying out and having nosebleeds and that kind of stuff. Okay. Okay, I see that's still not quite helping. We're going to go to the max of 6 liters. It's as high as you can go with a nasal cannula is 6 liters. The lowest is 1 for an adult. So 1 to 6, I know that's quite a bit and it feels kind of itchy. Let's see if it makes your oxygen go up. Okay, it's been about 5 minutes, sir, and your oxygen is still low. You're sitting about 90%. So I'm going to go to a different modality here. I'm going to use what's called a Venturi mask. The Venturi mask allows us to use a specific FiO2. So it comes in several parts. You have these ports. Room air starts at 21%. For every liter, you go up 4%. So he's on 6 liters right now, so that would be 28. So he's above 40. So I'm going to start at 50%. And how I know it's 50% is it tells you right here on the end. It tells you wet FiO2 and it tells you the liter flow. And sometimes it's up here, sometimes it's down here. So this one is 50% and it's 15 liters. So this connects to here. Put your cord on. This connects to the mask here. Okay, and then sir, I'm going to take this cannula off of you. I'm going to put this mask on, okay? There we go. Now those straps are soft, and we do put it behind the head on that one. If it gets too tight, it'll pop off. Okay. This one, we're going to go up to 15 liters. Like I said, you just go with what this is. Now, if you have a patient on a Venturi, make sure you don't cover this or they will not get that FiO2 that you want. If you have a kiddo on this, you don't want to burrito them up and have that in the blanket. Make sure that is exposed because it pulls in room air just to get that specific FiO2. Both ports need to be open. We'll give him a few minutes on that. His respiratory rate's still a little high. He's kind of working. His oxygen's not coming up much. He's at about 92% right now. So, okay, it's been about 5 minutes. Oxygen's still not coming up. since we're at this much, we're at 50%, I'm gonna go ahead and notify the doctor, and then I'm gonna put them on 100% with a non-rebreather. So, this is a non-rebreather. It has a bag. You see how it's flat? Anytime you put a patient on one of these, you want this bag to be fully inflated. So I always put it at 15 liters so I know it's fully inflated. Just gonna switch your mask out here, sir. Okay, you can make it inflate by holding that little valve. And there's one valve here that keeps that closed. It's just, and this is your inlet and this is your outlet. It's a one-way valve. And you want this bag fully filled so they don't breathe back in their CO2. Everything that they're breathing in is coming from this bag. It's just, and from the wall. It's a reservoir. So, okay. There we go. Now his oxygen is 95. We'll definitely notify the doctor and see if maybe he wants to get a blood gas or if we need to go to a different modality. He might need something a little more, maybe like a high flow or a BiPAP or something like that. We'll let the doctor decide. So we'll watch him and let the doctor decide on that. Okay, I want to go over this little doodad. It is called an incentive spirometer. We use them a lot in the hospital. It helps to prevent pneumonia. It reminds our patients to take a big deep breath because a lot of times they're laying in the bed and they're not taking those deep breaths like we would at home when we get up to go get a snack or a drink. And so we always tell them, hey, work on this. We want you to do about 10 breaths an hour. In the package it comes in, it has a paper. And you'll talk to your patient and you'll ask them, hey, how tall are you? Oh, you're 5'8", okay. So on the thing, I'll look at their age. I always look at their band for their age. I never ask because that's rude. So I look at the band and then I ask them how tall, and you follow it and it'll tell you what their max should be. If they've had surgery, you'll half that. You'll make it their goal. So say he had surgery and his regular is 3,000. We're gonna do 1,500. So we'll make that his goal. And I'll always instruct it. Sir, my name's Jamie. I'm with Respiratory. I have a little breathing exercise for you. This little guy's going to help you remind you to take a big deep breath, okay? What you're going to do is you're going to hold this in your mouth and suck on it like a straw, like you're drinking a big strawberry milkshake. So you want to take a nice, slow, big, deep breath, and you'll see this little thing rise, and you want to keep this blue thing in the middle, okay? They want you to do that about 10 times an hour. The easiest way to do that is if you're watching a TV show and a commercial break comes on, pick it up and work on it. Do 2 to 3 breaths every commercial break. That way you don't get worn out. Or if you're reading a book, every chapter, pick it up and work on it a few times, okay? Okay. Okay, I'm going to talk about and show you guys how to suction the nair to do NT suctioning. I'm going to let my patient know that it's not comfortable, but it's going to help get the secretions that are just sitting there. A lot of times when our patients aren't mobilizing or they're really weak, they cannot get those secretions up, so we can go get them and help them with that. One thing I want to point out is your nair goes downwards. So when you do suction, you don't want to push it back, you want to kind of go down. We always use lubrication for this, just to help it slide in there. And it's always a sterile procedure. So we open a new catheter kit every time. In that catheter kit, I always take my lubricant and I put it in there, right there, so I can do my little catheter in there. And then I open my gloves. And if you'll notice, I already have a set of gloves on, and I'll show you guys why. So I'm gonna do this sterile technique. Tiny. Do we have?
What size do you need?
Sorry guys, these gloves are really, really small. I'm trying to do sterile, but doesn't want to go in there. Okay. Got it. And if this one's not on all the way, that's okay. Once you get this one on, you can fix it. So, go for this guy here. Okay. So both my hands are sterile. A lot of times I'll get a buddy to help me hook it up to suction, or I can do it myself. But when I do it myself, then I'm going to have a dirty hand, and you have to be very mindful that which hand is clean and which hand is dirty. I'm going to pick up my suction catheter. This thing is sterile since we just opened it, and I'm going to put it in my lube that I pushed in there. Okay, I got a lot of lube on there. Okay, this is going to be my sterile hand. I'm going to grab my suction with that and connect this. So now this is my dirty hand. I will not use this on the catheter at all. Okay, sir, I'm going to suction your nose out here. It's going to be a little uncomfortable. It's going to make you cough a lot, okay? Very good. Okay, so I'm going to put that in there. And you have to be real careful because they're going to kind of move a lot, and sometimes it's good to have somebody to hold their head. And I'm going to push it down. Eventually, I'm going to hit a little where it's hard to go in, and I'm going to say, sir, can you cough for me, please? Cough real big. I know that's not comfortable. Cough, 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 cough. And as soon as I cough and I get past that, then I'll push it down and get it down in their airway. Okay, and then I'm going to suction. When I suction, I'm going to twirl as I come back so I can get all the yucky stuff in there. Okay. Alright. Okay, we're going to give you a break for a minute and then we're going to go back in, okay? I know that's not comfortable. I'm sorry. Okay, and if they're on oxygen, my buddy will put them back on their oxygen or whatnot. Okay? Alright, we're going to go in one more time. I know it's not comfortable, but it's going to make you so much better. There we go. Okay, cough, 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 cough. Good. Good. Okay. I'm on my way out. That's it. Good. And I'll make all kinds of noise, and you'll see all the yuckies in there, so you can chart what color. So this guy got some nasty creamy yellow. So we might tell the doctor that we want to send a sample, he might have an infection. And that's our NT suctioning. I was told you guys about the gloving. I always wrap this around my clean hand that I kept sterile, and then I am able to take that off and throw it right in the trash. And then I still have a clean hand to take care of my patient, put them back on oxygen or whatever I need to do. And so that keeps me clean. I want to teach you guys about how to clean a trach. My friend here has a trach, but first I want to explain the difference between an endotracheal tube and a trach. You'll see the endotracheal tubes and trachs both in ICU. A lot of people go home with trachs, so it's very important that we understand and we know how to take care of them, and that we can teach our patients how to take care of them. I want to show you the difference. This is an endotracheal tube. This is a trach. See the difference in size? That's a huge difference. So when we suction, we have to be very, very careful, especially with our trachs, because you can cause a lot of trauma down in their airway. And so here we have a suction catheter, and I'm going to put it in the ET tube, the endotracheal tube. Slip right out. And show you how far that goes. So this sits right above the carina, the endotracheal tube does. The carina is where your bronchus splits off to each lung. And so we like it to sit about 4 to 5 centimeters above that. So if you can see how far that suction is in to clean that and to get all the yuckies out. I call it the lung butter, but to get the sputum out of there, that's a big difference. So when we go down, we meet a little resistance. We come back so that we don't cause trauma, and then we'll hold the button and we'll suction it out. So to be mindful, so you can see how that fit easily in that endotracheal tube, you have to be really careful with these. And so what I like to do is I take the inner cannula, which is this. That's what goes inside the trach. These are disposable. Some of them are not. At the hospital, most of them are, and we just throw them away. But these we have to keep really clean because they can get blocked off. And so what I like to do is I like to take this out and take my suction catheter and see the difference and see how far it goes. See the difference of that from the endotracheal tube? So I'll look, this has numbers on it. So I'll say, okay, 11's probably my limit. So when I suction, I'll be mindful of how far to go down. So with this in here, sir, I'm just gonna put your cannula back in. And this has a twist lock. So when I suction him, I'm not gonna go very far down. I'm gonna see that 11 and then just go a little bit, and then I'll suction. That way I'm not causing irritation or you know, causing any kind of scarring with that lung tissue, with that, his bronchus, his airway. So that's very important to look out for. And you'll see inline suctions. You'll see these a lot of our trachs have them. This one is made for an endotracheal tube. We do have ones made for a trach tube that are shorter. So if you put one of these on your patients, make sure you have the correct one, because you can see how far this one goes compared to the trach. This one goes all the way down, and then you'll suction. So with this guy, since I kind of know where to go, and these usually have numbers, it's just kind of worn off, I'll go in. And sometimes it's kind of hard to get in there with the way that inner cannula is, so you have to twist to get through that. Let's see if I can get it in there. Doesn't want, there it goes. And then you go on down and then suction a little bit. And that's it for your suctioning. Okay, I'm going to teach you guys about trach care. You'll see a lot of patients with trach, so it's very important to be comfortable with them. You're going to have to teach these patients how to clean them before they go home, and how to change the trach ties and all that stuff. I'm going to open this unopened package here. Okay. Put on my sterile gloves. Sterile. And then I'm going to take these medicine things, and I'm going to put peroxide in one and sterile water in the other. So there's my peroxide, there's my sterile water that came in the kit. Okay. And then I'm going to take the 4x4s. I will soak this one in peroxide, and then I'm going to wipe around. Sarah, I'm going to clean your trach there, okay? I will wipe around the flange here, oops, and clean it real good. One wipe, and I'm going to throw that away. You don't wipe it a whole bunch, because if they do have an infection, or if you happen to touch something else, you just spread that all over the trach. So it'll be one wipe, throw it away. You'll get a new one, put your peroxide on there, and then do another wipe. You'll want to make sure you get back behind here and clean behind that flange. Once you've gotten that all wiped down and clean, then you're going to go back and use new 4x4s, newly opened 4x4s, and you're going to clean it off with water. You do not want to leave peroxide on a trach, especially if it's a new trach, because peroxide breaks down your red blood cells, so it'll slow down your healing. So you'll take sterile water, and then you're going to go back and wipe off all that peroxide that you put on there. And same thing, one wipe, throw away, sterile water, one wipe, throw away. This inner cannula, this one turns to come out. Some of them clip to come out or go in. If it is a non-disposable one, we'll put it in peroxide. We'll have a bigger cup and we'll let it soak while we're cleaning his trach. And usually we'll have a wire brush and we clean the inside of that really, really good. Once we've cleaned it, we're gonna of course rinse it off in our sterile water, use another brush, clean it out, dry it, and then we're gonna put it back in the trach. Right here. Just like that. In your kit, there will be a dressing that goes underneath the trach here. And that just keeps the flange off the skin so it doesn't cause any irritation. And so this, I like to pick up one side at a time. It's gonna make him cough a little bit, that's fine. Sorry, sir, I know that's a little uncomfortable. And I'll pull it up on one side and then I do the other. And I always address the ties. So his ties look a little soiled, so I'm gonna change those. Now, every time I change those, I undo one side at a time because I do not want to lose a trach. And if you will notice where I'm standing at the side of my patient, because if my patient coughs and I am in front of this trach, trachs are pretty powerful when people cough, and that will go right on you, and you don't want any sputum on you. Okay, so I'm gonna undo one side, and I'm gonna hold that. Especially if my patient's irritated and they're coughing, he can cough that trach out, and then I lost my trach. And sometimes if they're brand new, that hole closes up pretty quick, and you're not able to get it right back in. So I always hang on to that really tight. And so what I'll do is I'll take my new one, and I'll go ahead and I'll put it in there. Got my new one in there, and then I'll connect my other new one to the end of this, and I can pull it over here and then undo this side and then reconnect. Now if you notice, you have this Velcro on the end. You can fold it so that way it's easier to put under that flange and it'll slide right in. Okay. Alright, now that I've irritated that trach quite a bit, moving it, cleaning it, all of that, I'm going to want to suction. So I'll take my 14 French or the inline like I showed you guys, and I'm going to go down and suction. And I'll always remember, and sometimes what I do is on my chart that I write down, my report, I'll write how far that needs to go, or I'll write it on the whiteboard so the other people taking care of the patient knows. Okay, sir, I'm going to suction your trach now. I might make you cough a little bit. Okay. And then, okay, and if it's really thick, I'll take some saline, drop it down there, let them cough a little bit, but be careful, stay on this side, and then I'll go back in. Okay, and that is how you do trach care. The end.